I'm Malavika, and in this video we'll be learning about diuretics. So this is part 1 of the video where I'll be explaining the classification of diuretics and loop diuretics. The prototype drug is furosemide. So I'll be explaining the mechanism of action, actions, uses, adverse effects and drug interactions of furosemide. Diuretics can be broadly classified as high efficacy diuretics, medium efficacy diuretics, and weak or adjunctive diuretics. High efficacy diuretics include loop diuretics like furosemide, bumetanide, and toracimide. Medium efficacy diuretics can be further divided into two types, thiazide diuretics and thiazide-like diuretics. Thiazide diuretics include hydrochlorothiazide and benzthiazide. Thiazide-like diuretic example is chlorothalidone. Weak or adjunctive diuretics can be classified into three categories: carbonic anhydrase inhibitors, potassium sparing diuretics, and osmotic diuretics. Potassium sparing diuretics can be further divided into two types: aldosterone antagonists and renal epithelial sodium channel inhibitors. An example of a carbonic anhydrase inhibitor is acetazolamide. An example of an aldosterone antagonist is spironolactone. Example for renal epithelial sodium channel inhibitor is amiloride, and an example for osmotic diuretic is mannitol. Loop diuretics. As I said earlier, the prototype drug is furosemide. First, we have the mechanism of action. The site of action is at the thick ascending limb of loop of Henle. So, what do these loop diuretics do? They inhibit sodium-potassium 2-chloride cotransporter present in the thick ascending limb of loop of Henle. So this is a diagram showing the entire mechanism of action. So here we have the lumen of the kidney tubule where we have the tubular fluid. This is the tubular cell and this is the interstitium. So at the luminal side, we have the sodium-potassium 2-chloride cotransporter, which transports one sodium ion, one potassium ion, and two chloride ions into the tubular cell. Potassium ion will be pumped back into the tubular fluid with the help of potassium channel. Sodium ions will be pumped into the interstitium with the help of sodium-potassium ATPase, and the potassium ions which were pumped into the tubular cell will leave the cell with the help of potassium channel. Chloride ions will be pumped out into the interstitium with the help of chloride channel. So this is the normal mechanism which happens in the kidney tubules. Now loop diuretics will act at the luminal side of the tubule. It will inhibit sodium-potassium 2-chloride cotransporter. So all these ions will be retained in the tubular fluid and will be excreted through urine. This will further increase urine output, thereby causing diuresis. So this is the mechanism of action of furosemide. Pharmacokinetics. It is rapidly absorbed orally. Its bioavailability is 60%. In severe congestive cardiac failure, its oral bioavailability is reduced. So parenteral route is preferred to oral route. Its lipid solubility is low and its plasma protein binding capacity is high. Now about the metabolism, it is partly conjugated with glucuronic acid. It is excreted mainly in the urine by kidneys, but some amount is excreted in bile and also directly in the intestine. Its plasma half-life is 1 to 2 hours and half-life is increased in conditions like pulmonary edema and renal and hepatic insufficiency. Dosage 20 to 80 milligram OD, that is once a day in the morning. Actions of furosemide. Actions of furosemide can be remembered from the word furosemide itself. Just remember the letters F, U, S, E, M and I. F stands for free water clearance, that is, furosemide will block positive and negative free water clearance. And the reason for this is because furosemide will abolish the corticomedullary osmotic gradient. Now we have U, which stands for uric acid. that is furosemide will lead to hyperuricemia. There are two reasons for the same. The first one is that furosemide will compete with uric acid for tubular secretion, so this will decrease uric acid excretion. Next is furosemide causes diuresis, so ECF volume will fall and this will stimulate reabsorption of uric acid in the proximal convoluted tubule. Next we have S, which stands for increased synthesis of prostaglandins. Now prostaglandins are known for causing vasodilation. This will increase the renal blood flow, increase systemic venous capacitance and decrease left ventricular filling pressure. Now this is the reason why it is useful in left ventricular failure and subsequent pulmonary edema. Next we have E, which stands for excretion. That is, furosemide will increase the excretion of water, sodium, potassium, chloride, calcium, magnesium and bicarbonate. Now a question which may arise here is that since it causes excretion of bicarbonate ions and bicarbonate is alkaline in nature, will it cause acidosis? The answer is no, it will not, because here chloride excretion is also increased and chloride is acidic in nature. So increased excretion of bicarbonate will not cause acidosis. M, which stands for mild alkalosis. Now this action is seen only at high doses. Furosemide will cause diuresis, so this will decrease ECF volume and this will stimulate the renin-angiotensin-aldosterone system, and aldosterone will increase the excretion of H plus and K plus ions. Increased excretion of H plus ions will lead to mild alkalosis. Next we have I, which stands for inhibition. Now this is the primary action of furosemide, which we have already discussed. It inhibits sodium potassium 2 chloride co-transporter. It also has a weak inhibitory action on carbonic anhydrase. So this was all about the actions of furosemide. Uses of furosemide. It is used in edema. It is preferred in congestive cardiac failure, nephrotic edema and in chronic renal failure. It is used in acute pulmonary edema associated with acute left ventricular failure. IV furosemide is given, which will increase the synthesis of prostaglandins, and this will cause vasodilation and decrease venous return. So this will decrease the left ventricular filling pressure. Furosemide is also used in cerebral edema in order to increase the efficacy of osmotic diuretics. The next use is hypertension, but thiazide diuretics are preferred. Loop diuretics are used only in case of renal insufficiency, congestive cardiac failure and in hypertensive emergencies. Now furosemide is also used in blood transfusion in case of severe anemia in order to prevent volume overload. It is given in hyponatremia along with hypertonic saline. Furosemide is used in hypercalcemia of malignancy. Initially, IV saline alone is given and then furosemide is added to the IV drip. So this was all about the uses of furosemide. Adverse effects of furosemide. They include electrolyte disturbances, metabolic disturbances, ototoxicity and hypersensitivity. They can be remembered using the mnemonic HOME. Here, electrolyte disturbances include hypokalemia, hyponatremia, hypocalcemia and hypomagnesemia. Metabolic disturbances include hyperglycemia, hyperuricemia and hyperlipidemia. Ototoxicity symptoms include deafness, vertigo and tinnitus. Hypersensitivity reactions include skin rashes, photosensitivity and eosinophilia. Drug interactions. When furosemide is given with digoxin, it can lead to digoxin toxicity. Furosemide, when given with aminoglycosides, which are a class of antibiotics, it can increase ototoxicity. Furosemide plus NSAIDs. NSAIDs are known for inhibiting prostaglandins. So this will inhibit all the prostaglandin mediated actions of furosemide. Furosemide given along with lithium will cause lithium toxicity. Furosemide plus amiloride, this is actually a beneficial interaction. This is because amiloride is a potassium sparing diuretic, so potassium ions are preserved, and this will abolish the hypokalemic effect of furosemide. So that was all about part 1 of diuretics. Thank you for watching.